So, good afternoon, and thank you all for joining today's Health Equity Series session, a conversation on health disparities. I'm Dr. Kimberly Lamar. I'm the Assistant Commissioner for our Office of Health Disparities Elimination, and you are truly in for a treat today. Today, our discussion is on health disparities, but a little bit about racial disparities in general. So racial disparities, as a definition, refers to imbalances between the treatment of racial groups, including economic status, income, housing options, societal treatment, safety, and a myriad of other aspects of life. When we speak of health disparities, and particularly racial disparities in health, the data shows that racial and ethnic minority groups throughout the United States experience higher rates of illness and death across a wide range of health conditions, including diabetes, hypertension, obesity, asthma, heart disease, when compared to their white counterparts. Today's webinar sets the context for defining health and healthcare disparities, both in the United States as well as in the state of Tennessee. The objective of today's webinar is to examine race and its historical and present-day impact on health and well-being in U.S. and Tennessee. Joining us today, we have four great experts in this space, and I would like to introduce them. Our first panelist for today is Dr. Karen Scott. Dr. Scott is the Chief Black Feminist Physician Scientist, founder, CEO, and owner of the Birthing Cultural Rigor, LLC, and has more than 20 years of experience supporting women, girls, and persons across sexual and reproductive life courses in urban and suburban communities, both in the Midwest and in California. She is an improvement and implementation scientist and activist, grounded in Black feminist reproductive justice practice with formal training and experience as a community-based OBGYN and an applied epidemiologist. So please welcome Dr. Karen Scott. Our second panelist for today is Dr. Mary Fleming. Dr. Fleming practices as a generalist in Norristown, Pennsylvania Community Hospital, and she's been there for 4 years. And before deciding to transition to a full-time locum tenens physician. In this capacity, she has worked in several states across the country. This practice model also allowed her to travel to Kenya for 6 months to volunteer with Our Lady of Lourdes Mission Hospital in Mutombo. As an ardent champion of health equity, Dr. Fleming currently serves in clinical OBGYN shortage areas in Northeast region in Tennessee. She continues to explore avenues to grow her skill set to serve the vulnerable populations of this country globally. Please welcome Dr. Mary Fleming. Next, we have Dr. Linda Clayton. Dr. Clayton, Medical Director, Reproductive and Women's Health at the Tennessee Department of Health. Her career has concentrated in academic medicine, health policy, and population health. Dr. Clayton is the first African-American woman to be subspecialty trained in gynecological oncology. So please welcome Dr. Clayton. Lastly, we have Dr. Ingrid Cochran. Dr. Cochran is the Director of Communities for PACES Connection, a social network dedicated to raising awareness of positive and adverse childhood experiences, stress and trauma, and is adjunct professor specializing in developmental psychology, abnormal psychology, and African American psychology at the Tennessee State University. So please welcome Ingrid Cochran as well. So as we begin this session, I would want to begin this session by giving each of our panelists online today an opportunity to introduce themselves, as well as share a little bit about their background and their work in the area of health disparities. So I'll begin the conversation and give Dr. Karen Scott the first round of introductions. So Dr. Scott.
Hi, everyone. Dr. Lamar, thank you all for this opportunity. And sharing a little bit about myself and my background. I have recently left organized medicine or institutionalized medicine and established the Birthing Culture Rigor, which is a quality improvement and implementation science firm. Basically, I will explain that to mean that we formed as a living act of resistance against knowledge production and dissemination that produce racialized and misgendered or misogynistic misconceptions about Blackness, Black womanhood, Black birthing people that continue to undermine our humanity and justice in traditional quality improvement and implementation science. And so our mission is to improve the quality, safety, and value of healthcare experiences. That's the quality improvement piece, and to facilitate community and health system uptake of evidence, empathy, and equity-based interventions, and to practice some policy across the sexual, reproductive, and perinatal life course of Black women, mothers, and people. That is the implementation science piece. And so our vision is a more humane, just, and health system that integrates patient experiences and community wisdom and experience into health services design, provision, evaluation, and training. Our primary goal is to build hospital and community capacity and capability to recognize and respond to the phenomenon that we study and measure and intervene upon, which is obstetric racism, which is enacted upon Black women, mothers, and people who seek help or health care in hospital settings for any pregnancy-related condition, specifically with a focus on hospital labor, birth, and immediate postpartum. We continuously strive towards restoring the humanity and the sanctity of birth and hospital-based obstetrics and perinatal care for all communities by prioritizing the voices and experiences of Black women, people, Black women, mothers, and people. From my perspective about contextualizing race, or specifically racism within health disparities and healthcare disparities and inequities, I believe one of the reasons for what is happening is that current interventions and public messaging to promote health and well-being focus on individual behaviors when the data clearly shows that risk for adverse outcomes and experiences persist even after controlling for the contribution of individual behaviors. For example, a Black woman or person who achieves a college education can still remain 5 times more likely to die from a pregnancy-related condition than a white woman with the same level of education. So the problem is not individual race or gender. I believe the drivers of persistent inequities, in spite of individual social and economic achievements and advancement of a few with our communities, are driven by the presence of deeply entrenched systems and structures, that were designed to perpetually exclude our communities, particularly Black and other historically excluded or erased communities, from access to and utilization of opportunities and options for stable and sustainable income, workforce development, promotion, housing, clean water, education, safe neighborhood development. And with our existing weak infrastructures in health and public health, we have not been able to respond to the exacerbation of needs that have come upon us with the epidemic. So one of the things specifically around perinatal health equity and inequities, we have learned that despite the establishments of state and national perinatal quality collaborations, advancements in reproductive technologies, and social protections, again, such as higher education, hospitals are not keeping Black women safe. Some of the other drivers include a lack of clear ethical boundaries, a perpetuation of whiteness or white adjacent leadership, a hierarchy of knowledge construction that is still deeply grounded in anti-Black, racist, sexist, classist, and misogynistic ideologies and practices. Other drivers include poor science that continuously fails to illuminate the oppression, but also the resistance within our communities who have been long fighting against those harms that are enacted upon us across systems and structures. And one of the other reasons is that we have not funded communities to do the work. We have been funding predominantly white institutions to do the work, which again is grounded in ways that see us as suboptimal, as subhuman. So without community trust, transparency, and truth, we are failing in areas of health services provision and training and evaluation through dignified and equitable community participation and partnerships. And without these community participation partnerships, we will continue to weaponize race against the interest, humanity, and liberation of Black women, particularly in hospital settings. So some of the ways I believe we can implement change is the way in which we think about different measures, the way we identify the problem. And if we are not identifying the problem within the lived experiences of our communities, then we'll continue to recreate harm and error. So one way that we propose is creating a measure that's based on the lived experiences of Black women and birthing people to improve awareness, action, and accountability. This is our patient-reported experience measure of obstetric racism scale suite, which is composed of 3 independent measures of humanity, kinship, and racism. And so we believe by being able to quantify the experiences within hospital settings where we are measuring the behavior and language of any personnel within a hospital setting and linking the measure to the education, to the training, to the policies and practices within a hospital, we can then link transformation in hospital cultures to patient experience and ultimately to value-based reimbursement as it relates to improving healthcare and holding systems accountable. I also want to briefly mention that one other way is policy. In terms of policy, 2 big things I really want to push for is that we need to have state and federal legislation that mandates levels of maternity care. Currently, the public may be aware that the way we provide care in hospitals is usually informed and governed by the well-being of the infant or the fetus, which does not make sense because if the person who is growing and developing the fetus is not whole and healthy, then how can we save the child? So we need to build systems that of healthcare that are centered around the pregnant and birthing person. The other way is the Momnibus, which has been introduced lately, and it's looking at a way, again, to Build Back Better Act. And it's investing money and really examining social structural determinants of health. It's also investing millions of dollars in funding exclusive solutions that are originating from community-based organizations. It's also investing in a more broader perinatal workforce. We have to expand our concept of who is a provider beyond nurses and physicians and really look at midwives, doulas, lactation consultants, educators. So that is what I hope from our firm, that we can help build the infrastructure and the operations through measures and methodologies and training and education to improve equity and social justice and reproductive and perinatal health. Thank you.
Thank you, Dr. Scott. Dr. Clayton, I will give you some time to introduce yourself and tell us a little bit about your work.
Okay, thank you. It is such a pleasure to be here with everyone today. As Dr. Lamar indicated, I am a surgical gynecologic oncologist, and I have over 30 years direct patient care practice. And also, I am a public health practitioner. So in addition to my clinical work, my research has focused primarily on women's health, but also general health, from the standpoint of health equity. And initially, we were looking at primarily Black-white differences. My experience in terms of being interested in equity and the matter of disparities, it wasn't called disparities when my interest was first piqued. I first became interested as a child. I had 2 siblings who had polio, and indeed, they were not able to get their care at Duke, where I went to medical school. And I became a child healer in terms of being able to help to do the therapies that they need, as well as the personal care that they need. Then when I was 14 years old, I ruptured my appendix and ended up in the hospital at Duke. And of course, after my surgery, I was on this ward with mostly adults. I would say probably 85% adults. It was like a porch, and there were about 40 people there, and it was only a few teenagers and smaller kids. So I wondered, why is it that even when you have a major surgical procedure, in the situation we were in, why couldn't we all be integrated in the hospital system? So that's where my interest actually started. I went to medical school at Duke, and then after being in medical school, we had all of these wards that were named after these racist physicians. J. Marion Sims, the so-called father of gynecology. And of course, with all of that right in your face every day, I'm wondering, Duke at that time as now had a great reputation in terms of being one of the schools that provided everything you needed to be a good physician. So throughout my medical training, including residency, post-residency, fellowship training, I would see patients, and now we're talking about specifically oncology patients, and the Black patients always had more advanced disease and had many more comorbidities. So that's where my interest really started. Then I did a visiting professorship in the United Kingdom in Dundee, Scotland. And of course, I was in a unitary health system. And everyone, regardless of what your socioeconomic status was, you received the same level of care. And even people who lived in the Hebrides or way out, we had to go out to see patients who were beyond a university setting. It was a totally different situation. And then when I went to London, it was the same thing. People were getting a different level of care than I received personally or that my parents received. And I'm wondering, why is this? And how did it happen? And what can I do about it? So when I came back from overseas, I landed a position at Meharry as the director of, I started a division of GYN oncology within the Department of OBGYN. And one of the things I wanted to prioritize was to look at why do we have these disparities? So I became heavily involved. We received a grant from the NIH and we did clinical trials and lots of studies. So that's really where my interest focused initially, looking at what we called then, we didn't even call it disparities, it was Black-white differences. So that was in the mid 80s. And then in 1988, I met my husband who has passed away, Dr. Bird, and he was recruited back to Meharry to head up the Meharry Vanderbilt Alliance. And of course, we were asking him, what is this research? What are your research interests? And he said, I'm really interested in Black-white differences, but Dr. Foster doesn't want me to do that. He wants me to do something maternal child, but I'm really, really wedded. He had been looking at Black-white differences since 1968, when I met him in 1988, although we're not that much difference in age. So I said, oh, we can make it possible. So we talked to Dr. Foster. So he and I started to collaborate on a larger scale. Then we were advised, since we were doing both medicine research and some public health, because at that time, of course, they were calling on us to testify before Congress as it relates to Black health. So we were advised to go to Harvard to get our Master's of Public Health. So when we were there and we informed Dr. Blendon, the head of the department, and some others about the work that we were doing that was specific to health disparities, we were encouraged to stay, because we were planning to write the books on it, to stay and write our 2 books. So in order to complete the data collection, we ended up having to travel to Europe. We had to travel to Africa. We had to do a lot of primary research. And so over the period of a few years, we were able to complete the books, and our work as it related to looking at where is this coming from, the origins, evolution, and perpetuation and continuation of this Black-white other disparities in health and healthcare. So our books, the first two books were released in year 2000 and year 2002, An American Health Dilemma. And volume 1 is Beginnings to 1900, and volume 2 is 1900 to 2000. And we're working on volume 3 now. So I maintain my faculty appointment at both Meharry now and Harvard. So we're continuing to collect the data to look at the root causes in order, because you cannot solve a problem until you know where it came from. So in looking at the root causes of what my husband, Dr. Bird, termed the slave health deficit as it relates to Black health, because this is something we found out that didn't really start here in the United States with slavery. It started for Blacks with the slave trade. And we wanted to know why. What's causing this? And why is it that all the contributors are impacting our health? So we had to go back to antiquity, and we started with Plato and Aristotle, and found out that this whole way of seeing people in a hierarchical manner and treating people in a hierarchical manner, which has implications in society and healthcare. It started over 2,000 years ago. And this started with Plato and Aristotle, with the great chain of beings. And most of you are familiar with that, you know, God, the angels, human beings, and down to the plants, etc. So what Plato and Aristotle did in human aspect of the chain, they ranked the white man at the top, and of course it was some other man of color in the middle, and the Africans were at the bottom. And they used that as part of the reason to justify capturing us and enslaving us. And we found that for the US, or the transatlantic slave trade, our health, we were very healthy people in Africa before we were captured to come over as slaves. And starting with the capture, there was so many people who died from infections and hemorrhage from beatings, etc. Then in the storage area on the coast, before you move on the Atlantic voyage, you actually, once again, were dying of starvation, beatings, you know, infections, etc. And then after you land onto the North American continent, which we know now as the United States and Canada and South America, of course, then there were other types of environmental kinds of things, not just the beatings, but exposure to coal, no housing, no food, etc., which were the social determinants then. There was not a lot that could be done in terms of medicine and healthcare. So our deficit that we see now starts with slavery. And then once over that 246 years of slavery, our health was never at the same level as the whites. And the Native Americans' health was better than Blacks because they had traditional medicine, etc. We were not allowed as slaves to use our traditional medicine except in secret. So through that 246 years of slavery, our life expectancy was much lower, and we died lots of babies. And that's why they ended up breeding Black women so that they could keep the workforce from year to year. And they started working the children when they were 4 or 5 years old. If you can fan a white person, that's your work, that's your job. So life expectancy throughout that whole 246 years, then 100 years of apartheid. from the end of slavery all the way up until the civil rights movement. That's another 100 years of apartheid, where we had inadequate health care, inadequate food, inadequate shelter, inadequate clothing. And then finally, a group of Black doctors emerged during Black hospitals. Howard and Meharry were established right after Reconstruction. And I don't want to give a history lesson, but during that time, Meharry and Howard were the only Black hospitals for many years. And then over time, we had a total of 14 Black medical schools in the United States. And then, of course, over time, many didn't survive because of a number of reasons. And then just before, at the turn of the century, we had 7 Black medical schools. And then the Flexner came into being, the Flexner Report, to revolutionize medical education in the United States, not just the Black medical schools. But of those 7 medical schools, they closed 5. So only Meharry and Howard survived. And before, when we had 14 medical schools to take care of Black people because it was apartheid, those medical schools did the residencies and trainings for Black doctors and nurses. So there was at least some infrastructure. So now at the turn of the century, you've only got 2 Black medical schools, and it's still segregated. We could not go to the white hospitals. You have to remember that until the 60s. So, except a few exceptions. But so in the 60s, things became revolutionized from the standpoint of society and opening it up to Black people in terms of where we didn't have to show someone our driver's license just to go to town. So this is when we started to desegregate schools, was 1954, but of course, schools were desegregated, et cetera. And that moves us up in the last 56 years. So that's why we have to put health and healthcare in the context of what was happening in society. So one of the things that we must take away is that it's only been a half of a century since Black people in America could actually be admitted to hospitals in the United States on a regular basis. And we still have different levels of segregation, and we don't have time to talk about that today. So my training, we actually looked at this from the standpoint race, ethnicity, class, gender, etc. And that takes us till today.
Thank you so much, Dr. Clayton. Such a rich history, and I want to hear more about that in the context of present day. And I'm going to circle back to you for a few more questions, but I want to give Dr. Mary Fleming an opportunity to introduce herself, to share her work before we get into a Q&A with our experts. So, Dr. Fleming. You're muted.
Better?
There you go. Thank you.
So first, thank you so much, Dr. Lavar, for inviting me for this panel. I am very humbled to be on the same stage, if you will, with Dr. Clayton and Dr. Scott, who are doing and have been doing awesome work. My background is a little bit different. Like Dr. Clayton, I think, as kind of growing up and having the lived experience where kind of knowing things were different and not knowing why, kind of prompted me in medical school and in residency to try to figure out how I could affect change more than on the clinical level. So I was at Vanderbilt for medical school in Nashville, and then went on to Meharry, as Dr. Clayton mentioned, which has a very rich history in trying to provide comprehensive and equitable care. And so with that information, I knew I needed to add the vocabulary to what we were calling health disparities at the time. And so I went on to do a fellowship in minority health policy at Harvard in Boston, which is where Dr. Clayton and I crossed paths. And that was really influential in kind of setting my course, and it's very influential in one of the things that I'm doing now. And as you mentioned in my introduction, I did go on to do some work for a community-based practice right outside of Philadelphia, Norristown, Pennsylvania. I work mostly with the underserved population in trying to get my clinical skill set, if you will, tightened, if you will, before I decided to go out on the road. So like Dr. Scott, I realized that I don't think the best change or the best influence I had was on a one-on-one basis in the clinical system. I still love clinical medicine, and so I wanted to be able to do that, but I also knew I needed to create a space to be able to do something different. So I started doing locum tenens, which gives me the opportunity to travel, and I get to practice in different practice settings. So I worked in rural, urban, suburban, middle America, and also was able to practice out of the country. And those experiences really helped me understand how you adjust to different populations. And I like to say, babies come out the same way everywhere, right? But how that care is given is really based on the resources that are available, and changes, the dynamic changes based on the health system that we're embedded in. And so right now I kind of wear a few different hats. So one, the fellowship that I completed in Harvard was called the Commonwealth Fund Fellowship in Minority Health Policy, and the alumni component is called Reed Scholars. And the Reed Scholars are a group of physicians and dentists who are working in health equity in various capacities across the country. So some people are doing direct clinical work, other people are working in policy and government, and public health and academia across the board. But we really try to both support that cadre of physicians and dentists, because we know that it can be hard to be the only one in some of these organizations across the country. But so we provide support and synergy, and then we also try to provide education to a broader audience. So we have an annual health equity symposium. We have a health equity podcast that has been about 1.5 years in the making. So trying to make health equity a household conversation, and letting people know that health equity is not just, or healthcare is not just the healthcare you get in the clinic spaces, right? So all of these things that we're talking about, especially in your introduction, Dr. Lamar, about transportation, education, access to food, income and employment security, insurance access, all of those things influence how our health outcomes. The other thing that I am doing now is I'm working for a maternal health startup called Kayaba Care, which is based in Philadelphia. And so we are, again, trying to get at those social determinants of health by bridging the gap between the healthcare that is received in a traditional prenatal obstetric practice, but also help women have the resources they need to have their optimal health. So it's an at or near home solution. So we actually go out to her home at her convenience. Match the appropriate resources to for that person. So it's a very individualized and tailored care from prenatal, postnatal period, and then we try to bridge the gap back over to the primary care physicians in between. And then lastly, there's a new program that's just starting up at the Harvard School of Public Health this fall, which is a leadership development and equity in healthcare program. And so we also know that we have this momentum right now where we're talking about health equity a lot. We're talking about racism as a public health issue. And we know that there are a lot of people who have found themselves in positions that they might not have the training, the support, or the infrastructure to be able to have those crucial conversations in the healthcare space. So the program is for anyone who's in the healthcare space in a leadership role who needs that support to either transform their current position or move up into health equity position in their current or future space. So I think the moral of the story from all of our experiences that this is not a one-size-fits-all problem. This is not an easy fix. We have to come at it from every angle and really be reminded of the history. And I think it's very important, like Dr. Clayton said, that for the most part, this is 56 years, right? Like this, that we've even been able to have these type of conversations, and that the history that brought us to this point is important, and we need to recognize and understand that. So hopefully we can start to make change. So that's my story.
Thank you so much, Dr. Fleming. And next up, I want to introduce Ingrid Jackson, and I want to give you an opportunity to introduce yourself and tell us a little bit about your work in the area of health disparities.
Thank you so much. I hope everyone can hear me. I've been told I speak softly. Yes, my name is Ingrid Cochran. Actually, that's Jackson is my maiden name. And my background is really focused on stress and trauma. And currently, I am the director of communities for an organization called PACES Connection, which is a social media network really dedicated to the adverse childhood experiences study. And my expertise is historical trauma. I'm also an individual consultant for hospitals, schools, and other organizations who are attempting to address racial disparities across education and health. And so with my focus in historical trauma, I really focus on educating organizations, individuals around how we got to the point where we have health disparities in groups who have experienced historical trauma, namely Indigenous peoples and descendants of slaves. So when we look at the past and connecting it to disparities that exist today, specifically in health, and how we've experienced what we call scientific colonialism, where health disparities are largely focusing on genetic race as opposed to systemic issues in the past and currently that have created both issues around health like chronic disease, also disparities in mental health and all the physical things that come along with that, and really kind of, changing the narrative on how we talk about health of African Americans, Black people here in America, because it is often framed with this scientific colonialism, looking at genetic race and discussing Black health from the perspective of individual choices and poor decision making and things of that nature, as opposed to focusing on the systems, historical and present, that have brought about the situation that we see now in health disparities.
Wonderful, thank you and welcome, and thank you for that introduction. So I want to ask and pose a question to our panelists, and I know Dr. Scott touched on it a little bit, but I want to ask from your perspectives, with all of the historical context that we have around the history around the origins and the factors and influencers of health disparities, and even the research that has gone into this, and even looking through the current state of the pandemic and how many resources have been poured into addressing equity and disparities. In your opinion, why are disparities persistent? Why do they continue, given all of these factors currently? I'll open it up to Dr. Fleming, if you want to start that conversation, and then we can have everyone chime in.
Get to start, huh? With such an easy, light question, right? But I think it's multifactorial. I think, the system, I usually say the system wasn't built for us, right? And, listening to Dr. Clayton's brief history of the context of healthcare in this country, we were never included in the framework of the system to be cared for. And so I think there are just so many levels of oppression that are ingrained in the system itself that it's going to take time to to change those. I think when you're trying to change a systemic issue, it's multifactorial, and it requires everyone involved to play a part. And I think there are still, when we think about the leadership dynamics in this country, they still don't, for the most part, look like us, or are concerned with people who look like us, to be honest. And so until we change those patterns, I think it's going to be hard to change the system. I think the other thing that's, this is America, and America at the end of the day is a capitalist society. And I think a lot of the things that we talk about in healthcare around reimbursement and incentives have to also change. So I think a lot of people will do the right thing. However, we also have to have an incentive to do the right thing when we talk about all, well, I shouldn't say all, a lot of public health changes in that sphere. So I think we'll have to change the infrastructure of the system to incentivize the right decision around quality improvement.
Great, thank you. And Dr. Clayton?
Yes, I would certainly agree with that. And I'd like to kind of put it into a couple of buckets in terms of why is it that these disparities still exist over all this time? First of all, you'd have to look at the issue of quote unquote race. Race, we know, is not a biological construct. It is a socio-cultural construct. We have known that for a long time, but it is proven now, irrefutably, with the release of the findings of the human genome. We're all the same under the skin, okay? That means that we share 99.9% of our genome or genetic material with each other. Now, we know that with epigenetics that there can still be some mild kinds of things that can influence skin color, hair texture, or those kinds of things. However, it's one race. That's the human race. First, we've got to start seeing each other as equal human beings deserving of all the goods and services that are available in society, including healthcare. We know that systems of healthcare actually work in other countries. Of all the OECD nations, the United States pays more for healthcare and its outcomes are worse than any other. So that's one piece of it. The other piece, the social determinants, which we talk about all the time, those are driven by structural and systemic racism. We know that. So until we can deal with those kinds of social, the things that are driving the social determinants, then we're not going to get very far, because that impacts how we get illness or contributes to it. Then the next thing is the health system itself. As Dr. Fleming was saying, we've got to change the system such that it works for everyone. There are 12 identifiable components of the health system. And, it's not just the doctors and the nurses and the pharmaceutical, but it's all the other things which we don't have time to get into. But until everyone has equal access to the system of care and insurance, many people cannot afford it, okay? So until we deal with the structure, the social determinants, and then the care itself, once you get in the system, as we all know, there's a big move, and I'm happy that it is, on dealing with unequal treatment, unconscious bias. So until we deal with those kinds of things through cultural competence, understanding the class, cultural humility, all of those kinds of trainings that will help us, once we are in the system, to be treated equitably once we're there. And then, of course, there are other kinds of things, but those are the big three: the social determinants, the health system itself, and then the care once you're in the system. So those are big things.
Thank you so much, Dr. Clayton. Dr. Scott. And you're muted, I'm sorry.
I echo, essentially what Dr. Fleming and Dr. Clayton have stated. I think, number one, right, race is a social construct, just like many other things. And scientists, particularly data scientists in the field of epidemiology and quality improvement, continue to use race in their minds as a proxy for racism or any other structural oppression. So I always feel if we could reimagine, like use different ethical approaches, use different theories, use different methodologies that are grounded in our humanity, human-centered design, use different methods and measures that stem from the wisdom and expertise of people on this panel. We see most research teams, most think tanks are not led by us. And so imagine what it would look like for a think tank, for a research team, for a QI team to be designed, owned, and led by us, and for us to also get funding. I've written about the role of philanthropy in reproducing racial inequities and injustices because of philanthropic redlining. If only 8% of funding goes to people of color and 1% goes back to Black communities, but yet we have as little as a 3 to 4-fold gap in outcomes as great as to 12-fold, depending on what state you're in, related to perinatal death. We can't expect different outcomes if the funding doesn't align with the gap. That's all I ask. Fund us based on the gap. Have the leadership based on the gap, right? Have community representation as the principal investigators, as the gap. But instead we continue to, not we, but those in power continue to reproduce the notions that Black-led institutions, Black-led teams are fraudulent and inferior and ineffective. And that is absolutely not true. If people, I say, follow the data, follow us, like go where the data resides, go where the community resides, go where community scholars like ourselves reside, and also believe that public health is a common link. I think for the physicians here, we all have a master's in public health that totally transforms the way we approach not only the problem, but the solution, and bring humanities back into health services for human beings. We are just doing it really wrong. Not people on the panel, but those who are in decision-making capacities have taken the humanities out of healthcare for human beings.
That's wonderful, and I echo that, and I agree totally. And I want to give Ingrid Cochran an opportunity to weigh in on that question as well, and then we're going to also have opportunity to hear from our participants on this session.
Thank you, and I think Drs. Fleming, Scott, and Clayton have really covered a lot that I would attribute to kind of one side of this issue. The other side is the individual or those who have experienced what we would call intergenerational transmission of trauma. And so several things would need to happen with that. First, we would need to acknowledge it as a factor. So one thing that the medical community is great at is classifying, labeling, and things of this nature. And so once we have a label and a clear definition of historical trauma and operationalize what it means to treat people who have experienced historical trauma, not just historical trauma, but also generational poverty, then you can look at what it means to have a different type of course of action for them. So individuals who have dealt with historical trauma and intergenerational transmission have had impact to their DNA. So when we think about epigenetics, stress and trauma result in allostatic load and create the processes of chronic disease. And as long as we have environments that are stressful and traumatic for people who have experienced historical trauma, then they will have poor health outcomes, which have absolutely nothing to do with the color of their skin. So it's more about the environments that are created. And if we begin to operationalize that in the medical field, then that may be a different course of action, more aggressive treatment, a different way to interact with patients. But we would have to acknowledge that it is an issue and that it needs to be addressed. And there's so many different ways to address it. I mean, I've talked with Vanderbilt students in the past, and some have even brought up genetic therapy, things of that nature. But we would have to say that it's an issue first, and what it means to address it in ways that can be operationalized. In my experience working with the medical community as an outsider, it has been very difficult to talk about things like this because it's very, trying to think of the best way to say it, but it's basically people in the field are just very straightforward and they like to operationalize things, have checklists and things of this nature. And how do you quantify racism? But if we have a working definition for historical trauma, intergenerational transmission, and are able to make sure that we give people with this background additional care or more aggressive treatment and what that looks like, then that may be something that we can do. And then we need to educate groups who are our victims of historical trauma. So when it comes to how it's passed along through generations, it looks like people of color, specifically Indigenous and African Americans, experiencing more complex trauma in their lifetime, not just from a racist system, but also within their own families. So African American children going through the process of racial socialization may experience more physical punishment, may experience more emotional abuse or neglect within their own families. This then drives their epigenetic changes, the amount of stress and trauma that they experience in their childhood, that then can lead to the likelihood of developing chronic disease and other issues. Also, how we pass on the beliefs and values that we have around medicine. So if you're taught to distrust doctors, then you'll be less likely to go to the doctor. And so because of that past, if my grandmother tells me, don't go to the doctor, we have this home remedy, then that's what I'm going to do. And I'll be less likely to interact regularly with medical professionals because of that distrust. And so I would say that we really need to think about what does it mean to operationalize our approach to people who have dealt with historical trauma and intergenerational transmission.
Thank you so much, Ms. Cochran. And, we're running up against our time, and I think we only have 1 minute left. But I am feeling a need that we need to go and we may need to have a part 2 of this conversation, because I think, there's so much to unpack here and so much that goes into addressing health disparities and understanding these racial disparities. And so I think we're going to move in that direction, Matt, and I think that's something we want to put on the agenda. But I do want to thank you all for just taking the time to share with us. We had a great conversation about the historical context of disparities, and I look forward to hearing more. And I want our next session, if we can get you all back together to talk solutions and help our listeners and our participants on today understanding what they can do to be change agents in this space to help move our communities toward improvements in terms of narrowing the gap between Black and white disparities. And so more to come. And again, I thank you all for participating today. And I appreciate the insight that you've been able to share with us. So thank you.
Thank you.
Thank you. Thank you, everyone.
Okay. Thanks, everybody.